Afternoon, everyone. I'm Tara Chandrasekhar, an assistant professor of psychiatry and behavioral sciences, and I'd like to welcome you to the fourth webinar in the Taking Care of Yourself and Your Loved One series. This series is designed to help support the mental health and well-being of our faculty, staff, trainees, and students. Today, we're going to discuss suicide prevention, a difficult subject, but one that's so important to talk about. Suicide is a leading cause of death in the United States. And with increasing rates of mental health challenges during the pandemic, it's more critical than ever to know the signs that you or someone you love might be at risk and what to do if you find yourself in this situation. In this webinar, Dr. Nathan Kimbrell is going to help us understand the risk factors for suicide, offer ways to talk to others about suicide, and provide guidance on when and how to seek help. Dr. Nathan Kimbrell is an associate professor in the Department of Psychiatry and Behavioral Sciences. He's also the co-director of the clinical core for the Durham VA's Mental Illness Research Education and Clinical Center. Dr. Kimbrell has published more than 150 peer-reviewed journal articles, many of which focus on the prediction and prevention of suicide, particularly among individuals exposed to high levels of traumatic stress. The majority of his current work in the area of suicide prevention is aimed at improving clinicians and healthcare systems' ability to identify individuals at increased risk for suicide and finding novel ways to disseminate brief but effective interventions to high-risk populations. Before I turn it over to Dr. Kimbrell, just a few quick notes about submitting questions today. You can use the Q&A feature at the bottom of your screen and ask a question at any time during the webinar, but we'll hold off on responding to questions until at the end of Dr. Kimbrell's presentation. Please note that you have the option to ask a question anonymously. And now welcome, Dr. Kimbrell. Thank you for being here today.
Thank you so much, Dr. Chandrasekhar. It's a pleasure to be here with everyone today. Let me just go ahead and share my slides here. Okay. Again, it is a pleasure to be here with everyone today. The topic of our talk today is understanding and preventing suicide in adults. I'd like to start out just by mentioning the scope of the problem. This has already been touched on previously, but in 2016 alone, death by suicide accounted for 800,000 deaths worldwide and was responsible for more deaths than Parkinson's disease, ovarian cancer, thyroid cancer, Hodgkin's lymphoma, natural disasters, war, opioid use disorders combined. So that really is a startling number to consider. Within the United States, suicide is also the 10th leading cause of death. And to put that number in context, there are 2.5 times more suicides each year in the United States than there are homicides. And in 2019 alone, 47,511 Americans died by suicide. In addition, we estimate that there was 1.38 million suicide attempts in the United States. Perhaps most concerning, the suicide rate in the United States has steadily increased by 35% since 1999. As you can see here, the overall rate, which is the middle line, has increased from 10.5 deaths per 100,000 in 1999 all the way up to 14 deaths per 100,000 in 2018. On the top line, you can see the increased rate of suicides that we have been observing among men for many, many years. You can see that among men, the rate has increased by 17.8 per 100,000 all the way up to 22.4. And among women, the rate has increased from 4 per 100,000 up to 6.2 per 100,000. So what do we do whenever we believe someone we know, including ourselves, or someone we may love, is at risk for suicide? Well, I'd like to present today two complementary approaches for communicating with someone who may be suicidal. The first of these is the SAVE approach, which is one of the first gatekeeper trainings that was ever developed. And the idea behind a gatekeeper training is that anyone can help prevent suicide by simply helping to identify somebody at risk, speaking with them, and connecting them with care. I'd like to point out from the outset that much of what I'm going to talk about today was developed by Dr. Janet Kemp and her colleagues at the VA's Center of Excellence for Suicide Prevention in Canandaigua, New York. And this has since been turned into a freely available training that's available at psycharmor.org. It's the SAVE training, and Dr. Megan McCarthy narrates that training, and it's quite excellent. I recommend it for everybody. Another tremendous resource that we'll be talking about today is the 5 action steps for communicating with someone who may be suicidal from the Be the One to Save a Life Foundation and website. And together, I think that both of these complementary approaches really provide an excellent framework for how to go about speaking with someone who may be suicidal. So what is the SAVE approach? Simply put, it's an acronym for the key steps that one should take whenever we encounter someone that we think may be at risk for suicide, again, including ourselves. And so the first step is identifying signs of suicidal thinking. That's the S. The second step is asking questions. The third step is validating the person's experience. And the fourth step is encouraging treatment and expediting help. So whenever we're talking about signs of suicidal thinking, the first and most obvious is a person thinking about or talking about or writing about death, dying, or suicide specifically. Those would all be obvious clues that we should pay very serious attention to the situation and proceed with the other steps. Obviously, threatening to hurt or kill yourself is again in that same category. Looking for ways to kill oneself. Experiencing hopelessness, talking about feeling hopelessness or feeling trapped, or major changes in behavior. So rapidly increasing drug or alcohol use, engaging in reckless or risky behaviors, becoming very vengeful. Alternatively, it's not uncommon for people to begin withdrawing from friends, family, and society and to begin isolating. Perhaps missing medical appointments as well, which is something that we always want to pay attention to. Anxiety, agitation, major mood changes, and difficulty sleeping are all also key signs that we should pay attention to, in addition to giving away possessions or stating that you have no reason for living. So these are all the sorts of things that we want to pay attention to and watch. In addition to that, I'd just like to point out that there are a number of really robust predictors of death by suicide and suicide attempts that we should also consider within this context. The strongest overall predictor of dying by suicide or attempting suicide in the future is having a history of prior psychiatric hospitalization. The second strongest predictor is prior suicide attempts, prior suicidal ideation. So again, individuals who have engaged in suicidal behavior in the past, including being hospitalized for it, generally speaking, are our highest risk group. Lower socioeconomic status is also a risk factor. In addition, we frequently see stressful life events, recent stressful life events precipitate suicidal crises. In particular, financial problems, legal problems, and quite often relationship changes. So for instance, a relationship loss of a loved one, excuse me, would all be the sorts of things that we might anticipate preceding a suicidal crisis. Obviously, a prior screen on a screening instrument such as the PHQ-9, the last item, the suicidal behavior questionnaire, revised Beck suicide scale, all of those would be akin to, stating explicitly that a person is feeling suicidal and should be treated seriously. I'd also like to highlight the importance of both non-suicidal self-injury and personality disorders. Non-suicidal self-injury refers to engaging in self-harm behaviors for non-suicidal purposes. Typically, the prototypical behavior would be cutting or burning oneself to help regulate one's emotions. And this is often seen within the context of borderline personality disorder or other types of personality disorders. There's a common myth that we often see where people say there's doers and there's talkers. This is a complete myth. In reality, people that engage in non-suicidal self-injury, individuals with borderline personality disorder, individuals that have attempted suicide or talk about suicide are in fact the highest single risk group for going on and completing suicide in the future. So I just want to dispel that myth right now. There's also a couple demographic features of suicide decedents. These are things that I think are helpful to know, but really shouldn't necessarily influence your decision making. I just think it's helpful information. In general, as we've already seen, men are at substantially higher risk for dying by suicide, but conversely, women are about 50% more likely to attempt suicide. We see a pronounced risk in increased suicide among older individuals, particularly around age 75 and above. We also know that white Americans and American Indians are the racial groups that are at the highest risk. And because there's a much larger proportion of white Americans than American Indians, we see that, in fact, white men are the single highest risk group, or excuse me, account for the largest proportion demographically speaking. In fact, about 69% of all suicide decedents in the United States are white males. That's a pretty common number across the years. We also know that individuals, LGBTQ individuals are at increased risk, and we know that this occurs early on in adolescence and childhood. We see increased risk often occurring at the same time as transitions. We know that stigma and discrimination appear to lead directly to increased risk for suicide. So that's another important group to keep in mind. Veterans and individuals with a history of a mental health disorder are also at substantially increased risk. And in addition, access to lethal means, in particular, owning a gun or having a gun in your home, has been shown to increase risk for suicide for everybody within that home. So what do we do whenever we have identified somebody that we think is at risk for suicide based on the signs that we've just talked about? The single most important step is to ask the question, are you thinking of killing yourself, or are you thinking of suicide? When you ask, it's important to be direct and to specifically use the words killing yourself or suicide. And the reason for this is that words like hurting yourself are not specific, and as we've already talked about, could mean something else. For instance, non-suicidal self-injury. The person might also think you are referring to drinking a lot or any number of things. So what we want to do is we want to be very direct in our communication so that we're on the same page. While we're doing this, there's a couple do's and don'ts that I would like to point out from the SAFE training that I think are particularly important to consider. The first is to remain calm and to act with confidence while you're talking with the person. And the reason for this is, even though you may not feel that calm, we want to convey to the person that we can handle this conversation that we're having, and that they should not be afraid to tell us what their thoughts are. We also, of course, want to listen more than we speak. This is hard for many of us, myself included, but in this particular context, it's particularly important that we really try to hear what the person is saying. Maintaining eye contact is, always a good thing to do. And in particular, we want to also use supportive and encouraging comments, which goes hand in hand with the validation that we're going to talk about in just a second. Another really important point, though, is that we want to be as honest and as upfront as possible. And in particular, I would like to make sure everyone understands that you should never promise to keep someone's suicidal thoughts secret. This is not going to be helpful, and it will put you at a great disadvantage whenever you do, if you were to need to reveal that. So we want to be upfront as possible. We also don't want to argue with them. We don't want to judge them. And in particular, when we ask the question, are you thinking of suicide? We don't want to ask it as if we're looking for a no answer. We don't want to attach any stigma to this. So in particular, we don't want to say something like, you're not thinking of killing yourself, are you? Because in all likelihood, you're going to get a no answer there, when in fact, that really may not be the person's intent. The next step is the validation piece of it. We just hit on a number of these in the do's and don'ts and how we talk with people. But the most important thing we really want to do is we want to communicate to the person that we're here for them and that we're here to provide them with help. We're listening carefully and we're hearing what they're telling us. One straightforward way of communicating this is to simply restate what the person has said to make sure that you're hearing it right. Again, primarily focusing on listening, but also communicating to them that we are paying close attention to what they're telling us. We want to acknowledge their feelings. We want to provide them with as much emotional support we can. And as we're going to talk about in the next step, we also want to provide them with instrumental support, meaning that we want to help them in tangible ways get the help that they need. Again, we don't want to accept, we want to accept the situation and not pass judgment, and let them know that the situation is serious and deserving of attention. Finally, within the SAFE framework, one of the things that we want to do is to encourage treatment and expedite getting them help. This is where the instrumental support piece comes in. We want to explain to them that there are trained professionals that are available to help them, and we want to explain to them that treatment works. And I'm going to provide you some examples of treatment that work in just a moment, so that you'll be prepared with some answers there. We also want to explain that getting help for suicide is no different than getting help for any other type of medical problem, and that getting treatment for suicide and suicidal thinking is your right, just as it's your right to get treatment for cancer or any other medical illness. If they say, I've tried treatment before and it hasn't worked, which is something we hear not infrequently when we're talking about working with people with mental health problems. A great question to ask is, what if this is the time that treatment does work? So just to prepare you so that you are an informed individual, there are now a number of evidence-based treatments that have been shown to reduce suicide risk. This is not an exhaustive list by any means, but I do think that many of the top approaches are listed here. At the top of the list is lethal means restriction. And the idea of lethal means restriction is exactly what it sounds like. In the moment of a suicidal crisis, what we want to do is to delay the person having access to lethal means that could, in fact, kill them. And so one of the things that we know is that individuals who are experiencing a suicidal crisis often have a very one-track mind. They are not thinking clearly. And often they will be very focused on utilizing a specific method. And research has shown that if we simply do not make that method available, often people will not try a different method. Of course, best practice is to eliminate access to different types of lethal means that the person may have. But a key point here is just understanding that in the moment of a suicidal crisis, we really want to keep the person from having access to their to lethal means. Another approach that I am a really strong proponent of is the safety planning, intervention, or crisis response planning. Two different groups have kind of developed this approach, and I'm going to talk more about this in just a second. But I would like to put a plug in here right now that I think that all providers, in my opinion, would be extremely well served to undergo safety planning intervention training, because this 30 to 60-minute intervention has been shown to dramatically reduce the risk of future suicide attempts by 50% among a high-risk group. More long-term solutions include cognitive behavioral therapy for suicide prevention, which is exactly what it sounds like. It's CBT with a specific focus on preventing suicide. There are two different flavors of CBT for suicide prevention, one that is more emotion regulation focused and one that is more traditionally focused on cognitive therapy. Both have been found to be effective. Problem-solving therapy is another approach that has shown efficacy for reducing suicide attempts. And in particular, we know, again, going back to kind of the one-track thinking, we see often deficits in problem-solving skills, including social problem-solving deficits that often precede suicidal crises. Dialectical behavior therapy is something that Duke has a phenomenal program, has a phenomenal dialectical behavior therapy or DBT program. This is a more intensive treatment approach that includes both individual therapy and group therapy. It was originally developed for use with patients with borderline personality disorder. It is the gold standard for treatment with that set of patients, but it's also useful for a variety of different problems, all centered around emotion regulation. And importantly, DBT has also been found to be quite effective at reducing suicidal behavior as well as non-suicidal self-injury. Last but not least, there are a wide range of pharmacotherapies and psychological therapies that are evidence-based treatment for specific mental health disorders that also have been shown to reduce suicide. So just as an example of this, we recently examined 3 different psychotherapies for depression, and we found that each was associated with substantially decreased suicidal ideation from beginning of treatment to the end among patients that began treatment with suicidal ideation. Obviously, best practices here would be to get patients the appropriate treatment. So, perhaps lithium for bipolar disorder, SSRIs for depression, and so on and so forth. The idea here is it's quite important to make sure that the underlying treatments are being treated effectively, and often that will be sufficient to help the person prevent a suicidal crisis from happening. So I'd like to highlight here a treatment that I find to be particularly innovative in many ways. It was originally developed by Dr. Barbara Stanley and Gregory Brown. And this is the safety planning intervention. As I mentioned before, this is a pretty brief intervention, 30 to 60 minutes, that has been shown to reduce the risk of attempting suicide by around 50%. And that number comes from a study of high-risk veterans who were admitted to the emergency department for suicidal thinking. So, we feel like this is, other studies have shown this, but that was a recent paper in JAMA Psychiatry that really confirmed what many of us already suspected, which that this is a therapy that really makes a lot of sense. In particular, because of its brevity and the outcomes, I think it really is an ideal approach from a cost-effectiveness perspective. And the idea of the safety plan is that basically it's an emergency plan. Whenever we work with firefighters, for instance, we tell them this is your emergency plan for suicide, or this is your standard operating procedure. And we see that a lot of people really respond to this, and they understand whenever we present, the idea of the suicidal crisis, and that we're trying to prevent, an unfortunate suicide attempt at the top of the risk curve. This really makes sense to people. The first step is to help them identify their personal warning signs. So this is essentially helping them to know, when should I engage in using this plan? And then each step from there is kind of for an escalating level of risk. And so, if you see warning signs at step 1, proceed to step 2. If step 2 is not working, proceed to step 3, and so forth. Step 2 involves helping the person to identify solo activities to help them cope with their suicidal thoughts. And these are things that they can do on their own. It might be watching a funny movie. It might be going on a walk, exercising, etc. It depends on the specific person. Step 3 is to identify social distractions. So places they could go or people they could be around that will help keep them safe, but also help them to cope with their suicidal thoughts, although not directly. The idea here is a distraction. So for instance, going to a coffee shop, going to a hardware store, it could be any number of things, going to the movies. The next step is to identify at the time of the safety plan supportive family and friends that you could contact to let them know that you are struggling with suicidal thoughts and that you could benefit from some support, and also, potentially to, again, provide some instrumental support to help connect them to professionals if it gets to that. Ideally, they will tell the people ahead of time so that the person is aware of the safety plan and is aware that the call could be coming. And then the next step is to identify professionals to contact. And this is exactly what it sounds like, your mental health provider, the emergency department that you might be going to, as well as the National Suicide Prevention Hotline. And finally, step 6 is making the environment safe. And this is where we bring in the lethal means restriction. And that's one of the things that I really like about this intervention, is that not only does it have this straightforward plan that most people can really understand and get behind in terms of how to handle suicidal thinking, it also does one of the most effective things we know for suicide risk prevention, which is restricting access to lethal means. The last thing that I'd like to point out that's not included in the SAVE approach, but I think is a critical element that is included in the 5 action steps, is the follow-up step. So I would advocate for like a SAVE F sort of approach where we add an F to it for follow-up. And the reason we want to do this is that we know that helping people to feel supported and socially connected is one of the most important things that we can do for them, in addition to helping connect them to appropriate treatment resources. So simply following up with the person, finding out how things are going for them now, and to see if they need any additional support is always a great idea. Last, I'd just like to point out that, as we've shown before, Duke has a number of tremendous resources, including the emotional support and well-being line, Duke personal assistant services, obviously clinical appointments within the department. There's also a number of 24/7 options, including the National Suicide Prevention Helpline, Hope for NC line. These are some resources about what I was talking about specifically today about SAVE, as well as Be the One To. I would recommend all of these resources. In addition, SPRC, the Suicide Prevention Resource Center, an abundance of suicide prevention resources available, as does the American Foundation for Suicide Prevention. These are some safety planning resources. I would like to emphasize that this is an intervention, and I do not feel like anybody that I just explained this to is ready to go do a safety planning. I recommend that you get specific training, and there are a number of those trainings available prior to beginning that intervention, because it is in fact a specific clinical intervention. These are all great resources. And these are just some additional crisis resources that are available. And with that, I would be happy to take any questions. Thank you.
Thank you so much, Dr. Kimbrell. Such helpful information. We have a few minutes for questions. Please go ahead and submit questions if you have them. And remember that there's a way to submit questions anonymously. We do have one question. What are the top reasons that someone would take their own life?
That is a challenging question to answer because I believe that it's going to be fairly idiosyncratic for most individuals. I would say that it tends to be a culmination of a variety of stressors, is in my personal opinion. I think that the best model from my perspective, again, just my personal perspective, is a diathesis stress type model, where what we see is there's a lot of underlying vulnerability factors, and then that combines with a stressful life event or a series of stressful life events. And I believe that that is kind of the prototypical pathway that we see most often. But I think that there are certainly many different reasons that a person might take their life. And I don't know if you have any additional thoughts there, Dr.
I would agree, I think.
Shaker.
Yeah, and there's a confluence of events happening for individuals, and it's important to understand it on an individual level as well.
And I also think that that points out the importance of, for instance, the safety planning approach, where they're identifying their own unique warning signs. One of the things that we really emphasize when we're making those plans is a lot of times people will have a specific thought process that precedes suicidal behavior. No one loves me, I'm not lovable, I'm a burden to my family. And these sorts of thoughts, often if we can identify those, that gives the person a really good set of signals that they need to be, begin engaging in the safety plan.
Mm-hmm. Building self-awareness for the individual. We have another question. What is your explanation for the increasing suicide trend in the past decades?
Again, I will put the caveat that this is my personal opinion. I'm not speaking for anyone else. But if we look at those trends carefully, one of the things that we will see is that the trend among men and women has steadily gone up. But if you break it out by veteran status, you will see that veterans have increased, their rate of suicide has increased dramatically over the past 20 years, particularly in the past 10 years. And of course, there has been a war going on, and it's very likely that that contributes. The other factor is that if we look at firearm-related deaths, we see that in addition, the homicide rate has gone up, firearm-related homicides, but the firearm-related suicides have gone up dramatically in the last 10 to 20 years. And so that likely plays a role as well. We know that with veterans, veterans are far more likely to use a firearm. So that probably plays a role there as well.
There's so much that we could talk about, and unfortunately, we don't have time to cover all the questions. We will share the recording and the related resources in the webinar series webpage. And please note that the recording slides and resources from the first 3 webinars in the series is also available on that page. Thank you so much, Dr. Kimbrell, for your time.
Thank you. It was a pleasure.
Thanks for coming, and thanks for all of our attendees. We'd also like to invite you to join us for our next webinar, which will be on Wednesday, April 14th at 4 p.m. It'll focus on a similar topic, suicide prevention, but we'll focus on preventing suicide among children, teens, and young adults. And our speaker is Dr. Angelo Tuno. Information about upcoming webinars and recordings and resources from past webinars are available at the link in the chat. And you can also submit questions in advance of an upcoming webinar at this link. And finally, I want to end by noting that if you're struggling know that you're not alone. We encourage and invite you to seek support. Resources, including our department's emotional support and well-being phone line, are listed at the bottom of the webinar series webpage. Thank you. Take care. Hope to see you at future webinars.